Welcome everyone to our presentation on X-ray imaging positions for the thoracic spine and chest region. As radiologic technologists and healthcare professionals, it is crucial to understand the proper techniques and positioning for these vital diagnostic procedures. Let's begin by discussing the posterior anterior chest view. For the posterior anterior chest view, we set the source to image distance, or SID/FFD, to 72 inches to minimize magnification of the heart. The tube should be positioned without any tilt, with the central ray aligned in the midline, approximately at the T7 vertebral level. To ensure an unobstructed view of the lung fields, we instruct the patient to place their hands on their posterior superior iliac spines and roll their shoulders forward, abducting the scapulae away from the midline. We use a 14 inches by 17 inches chest cassette, with a grid and bucky, at 120 kVp. Proper collimation is essential, ensuring that at least 3 sides of collimation are visible on the radiograph and that the evaluation criteria are fulfilled. The marker should be placed inside the collimation area, without obscuring important anatomy. Patients should be instructed to suspend respiration after a full inspiration, allowing for the visualization of subtle lung anatomy. Gonadal shielding is mandatory for radiosensitive tissues outside the region of interest. The evaluation criteria for a successful posterior anterior chest view include the complete visualization of both lung fields, including the apices and costophrenic angles, with the spine just visible through the heart. Any artifact overlying the lung fields renders the study non-diagnostic. Transitioning to the lateral chest view, we maintain an SID/FFD of 72 inches, with no tube tilt. The central ray should be positioned approximately at the T7 vertebral level, in the center of the thorax in the anterior-posterior direction. For this view, the patient's left side should be placed against the bucky to reduce heart magnification, with their arms resting on top of their head. We continue to use a 14 inches by 17 inches chest cassette, with a grid and bucky, at 120 kVp. Collimation should ensure that at least 3 sides are visible on the radiograph, just under the 14 inches by 17 inches size, while still fulfilling the evaluation criteria. The marker should correspond to the side of the body against the cassette, a left marker for the left side, or a right marker for the right side. As with the posterior anterior view, patients should be instructed to suspend respiration after a full inspiration to visualize subtle lung anatomy. Gonadal shielding is mandatory for radiosensitive tissues outside the region of interest. The evaluation criteria for a successful lateral chest view include the complete visualization of both lung fields, including the costophrenic angles, with the entire body thorax visible. Any artifact overlying the chest renders the study non-diagnostic. Next, we have the apical lordotic chest view, which is taken to visualize the apical lung fields without the overlap of the clavicles and ribs. The standard SID/FFD is 72 inches, with no tube tilt. However, if the patient is unable to lean back, the tube is tilted 25 degrees cephalad, and the SID/FFD is adjusted to 40 inches. The central ray should be in the midline at T7, or alternatively, the cassette can be positioned 1 to 2 inches above the shoulder, with the central ray aligned to the cassette. For patient positioning, we ask the patient to stand 1 foot away from the bucky, facing the tube, and lean their shoulders and head back to rest on the bucky. Their hands should be placed on their posterior superior iliac spines, with their shoulders rolled forward to abduct the scapulae away from the midline. If the patient cannot lean back, they should stand in an upright posture, and the central ray is angled 25 degrees cephalad after moving the tube to a 40-inch SID/FFD. We use a 14 inches by 17 inches chest cassette, with a grid and bucky, at 120 kVp. Collimation should ensure at least 3 sides are visible on the radiograph, fulfilling the evaluation criteria. Patients should be instructed to suspend respiration after a full inspiration to visualize subtle lung anatomy. Gonadal shielding is mandatory for radiosensitive tissues outside the region of interest. The evaluation criteria for a successful apical lordotic chest view include the complete visualization of both lung fields, including the apices and clavicles. Moving on to the spot rib view, we set the SID/FFD to 40 inches, with no tube tilt. The central ray should be directed to the area of complaint, and the patient should position that area against the bucky. For this view, we use a 14 inches by 17 inches regular cassette, with a grid and bucky, at 70 kVp. Collimation should ensure that at least 3 sides are visible on the radiograph, fulfilling the evaluation criteria. The marker should be placed inside the collimation area, without obscuring important anatomy. Breathing instructions vary depending on the rib level. For ribs above the diaphragm, approximately T8 and above, patients should suspend respiration after a full inspiration. For ribs below the diaphragm, approximately T9 and below, Patients should suspend respiration after a full expiration. Gonadal shielding is mandatory for radiosensitive tissues outside the region of interest. On the SuperTech system, we select the appropriate technique factor based on whether the rib of interest is above or below the diaphragm, ribs AD for above the diaphragm, and ribs BD for below the diaphragm. Due to the curvature of the ribs, it is challenging to obtain a lateral view. By positioning the area of complaint closest to the film and aligning the central ray as closely as possible to the area of concern, we minimize distortion. The evaluation criteria for a successful spot rib view is the clear visualization of the bony anatomy in the region of clinical concern. That concludes our presentation on X-ray imaging positions for the thoracic spine and chest region. I hope this comprehensive overview has provided you with a solid understanding of the techniques and considerations involved in these vital diagnostic procedures. Please feel free to ask any questions you may have.